Chapters 13 through 16 in our Jarvis text cover head, eyes, ears, nose, the oral cavity, and the throat. In order to get the most from your reading, make sure that you review the anatomy and physiology from your textbook and understand the major functions of each body system. Consider how developmental, cultural, and genetic differences will change your assessment techniques and findings. Rehearse the subjective questions out loud and practice the objective assessment on a willing simulated patient. Review the documentation and case studies at the end of each chapter, and even practice documenting your subjective and objective assessments that you practiced. Create flashcards or concept maps from the abnormal findings section, and know the important patient teaching information. Beginning with the head, as you walk into the room, you're going to note the general size and shape of the head. You'll see that the eyes and ears are symmetrical and that the outer canthus of the eyes lines up with the upper end of the pinna of the ears. Hopefully the patient will make eye contact and smile, and you can see that the eyes are focused equally and that the smile is symmetrical. As you're assessing the head, you want to place your fingers in the person's hair, palpate the scalp, noting any deformities or lumps, and then part the hair and inspect the scalp for lesions, hair distributions, nits, or things like that, especially if there's a complaint of. If there is no complaint of anything related to the head, you would skip the palpation and the inspection of the scalp. With the eye exam, you start by inspecting the external eye structures. You test the visual acuity. You examine the pupils, inspect the extraocular movements, and then inspect the ocular fundus. You should be familiar with the external eye structures and use the correct terminology during documentation. The corneal light reflex, also referred to as cartoon eyes, indicates that the eyes are pointed in the same direction and that both of the globes or eyeballs have equal amounts of pressure. Normal corneal light reflex, light should be reflected in both eyes at the same location on the iris. So you can see in this picture that the ceiling light is reflected here on both eyes, and then the pen light from the examiner kind of in the room is reflected here. If you have an unequal corneal light reflex, then either the patient has strabismus, like cross eye or lazy eye, or they have an injury to the eyeball itself, or perhaps they even have a glass eye. The Snellen eye chart is checked at 20 feet when it's hanging on a wall. There are also pocket eye charts that you can use. Make sure you follow the instructions for the appropriate distance so that you're gauging the eyes correctly. And make sure that you're using an appropriate barrier for the eye that's not being tested. You want to test the eyes uncorrected, right eye, left eye, and then both eyes, and also check for color blindness or color recognition when you're doing things like CDL testing. A normal visual acuity, like for an injury, color differentiation is not part of the exam. The pupillary light reflex tests direct and consensual constriction to light. So the question was posed, what is wrong with this picture? And the answer is the examiner is holding the pen light in front of the eye. You should always direct the light from the side to avoid accommodation causing pupillary constriction. If the pen light is visible to the subject, it is possible that the pupil will constrict in an attempt to focus on the pen light, and you will get a false positive reading. Extraocular movements are checked in order to test cranial nerves 3, 4, and 6. Typically, you start with the patient's left upper gaze going this way and coming back, and then left lateral this way and coming back, and then left lower this way and coming back. So you're kind of moving in a clockwise direction, and then you're going to go right lower and back, right lateral and back, and then right upper and back. And then you're going to have, remember you're doing this at about arm's length away, which is roughly 3 feet. You don't want to be too close when you're doing this. And then you're going to bring the pen light in, or your finger, whatever you're using to test this, or your pen. And as you get closer, so this is your finger, you notice that the pupils converge and that they constrict, and that's called accommodation. So accommodation leads to constriction of the pupils in an effort to focus on an object that's up close. So once you have done that and you notice that the pupils are equal and round and reactive to light and accommodation, you can document PERLA. And if you don't notice those things, then you should document the abnormals, or don't document PERLA and be specific in your details. As you're examining the eyes, some other things that you want to look for would be a hordeolum or a sty. You can review these in your abnormals in your book. Blepharitis, conjunctivitis, iritis, and hyphema. These are pretty common eye complaints that we see. So a hordeolum or a sty is essentially like a plugged sebaceous gland along the eyelid. It's really important that you do warm compresses and don't pop it, or you can introduce a strep or a staph infection into the eyelid, which can become incredibly damaging. Blepharitis and conjunctivitis and iritis are all obviously irritation and sometimes infection, depending on the causative agent of the structures of the eye. And so those are treated oftentimes with antibiotics. Blepharitis is also can be treated with baby shampoo, diluted baby shampoo used to kind of clean and soothe the eye. And then hyphema is blood in the anterior chamber of the eye, usually from trauma, but it also could be from like a really forceful sneeze. And then you want to teach about things like cataract and glaucoma. So cataracts, you can see on the external structure of the eye. The problem with glaucoma is that it's painless and the vision may be lost before they're even aware of the problem. So it's really important that people have annual visual screening exams in order to make sure that they don't have any sort of internal pressure changes or problems going on. The fundal exam, again, we talked about this. You can do this just to enhance your knowledge and your skill. But these are the structures that you would see on a normal fundus. And if you see any obvious like bleeding or separation or or if you can't find the optic disc or the macula, you should let the physician know. For the ears, you start by looking at the external ears. Note the size and shape of the auricle, the position and alignment on the head. So the auricle is also the pinna. Note the skin condition. Is there any like crusts or flakes, any weeping or discharge? Check the auricle and the tragus for tenderness. Palpate the mastoid if they're complaining of pain, because ear infections can lead to mastoiditis, which can then become meningitis. Before you put anything in the ear, you want to pull the pinna up and back if they're over 3, or down and back if they're under 3. The normal tympanic membrane is pearly gray and concave, and acute otitis media, it's bright red with no light reflex. And if you see blood behind the tympanic membrane, you need to report that immediately. If there's blood and fluid leaking from the ear, the concern then is a ruptured tympanic membrane, which could be a sign of a basilar skull fracture or direct trauma to the ear. And in that case, we as the staff nurse would not probably be doing an otoscopic exam. You would leave that to a higher level provider because you don't want to introduce anything into the meninges. For hearing tests, depending on where you work, usually the whisper test, but if you're working in a higher level, kind of like an audiology type of setting where they do true exams, they may use other devices. Weber and Rin are not very accurate, so they're not used normally in practice anymore. So here's a picture of the normal tympanic membrane. Again, it's pearly gray, concave. You can see the structures behind it. And it has this nice little cone of light where the light from your otoscope is reflected. In otitis media, there is redness. It's bright red. It's injected. You can see that it's swollen. It's kind of bulging. And over here you have that cone of light, and over here you don't have that cone of light. So it's missing. It's absent. There's no light reflex. In the nose, the oral cavity, and the throat, you're looking for symmetry, deformity or lesions. With the nose, you can like plug one nair and have them breathe in through their nose, and then plug the other nair, have them breathe in through that nostril, and just make sure that you're testing the patency of each nostril. You can use the nasal speculum or even the otoscope to look inside the nose to view the mucosa, the septum, and the turbinates, and then palpate and even percuss the sinus area, observing for any drainage, purulent drainage, and sinus pressure are common complaints for somebody that has like a sinusitis. In the mouth and the throat, inspecting with a pen light or the otoscope. A lot of times if we have it out to check the ears, we're checking the ears, the nose, the mouth, and the throat all at the same time because you have the light out and it's handy. So you're inspecting with a light, the tongue, the teeth, the gums, the buccal mucosa, especially along the side of like the tongue, and then the palate and the tonsils. You can find leukoplakia or candida along the side, sometimes kind of hidden away. Remember to remove dentures. If dentures are in place, to look underneath for irritation or evidence of infection or ulceration. And then palpate as indicated if there's any pain, if there's any swelling or pallor, foul breath, anything like that. And it's important to observe their ability to swallow to make sure that they don't have dysphagia. When they stick out their tongue and say, the uvula should be symmetrical, hanging in the back of the throat, and it should rise symmetrically, and you're testing cranial nerves 9, 10, and 12 when you do that. And then look for changes in the gum line themselves. So we talked about hyperplasia being related to dilantin use. With age, the tongue becomes very smooth and the taste buds atrophy. The mucosa and the gums themselves thin and recess as well. If they have gingivitis or if they have really bad dentition, they might have inflammation, redness, and swelling, and terrible halitosis or foul breath. Abscesses are round and swollen, pale with surrounding redness, very painful to the touch, and those are usually at the level of the tooth root. Candidiasis is red, raw mucosa with a white cheesy coating that doesn't wipe off. And then ulcerations are whitish lesions on the mucosa that don't wipe off and often very painful. Also observe to make sure that they're well hydrated. Normal mucosa is pink and moist. Dehydrated mucosa has, like a thick biofilm coating and vertical fissures in the tongue. Just an example of how to palpate the sinuses. Don't be afraid to touch your patients. When you're examining the neck, it's important to understand the underlying structures so that you can palpate and assess the correct areas as well as auscultate the correct areas. When you're examining the neck, first you notice the position of the trachea. The trachea should be midline. Deviation can occur when you have a tumor within the tissues of the neck that push the trachea away toward the unaffected side, or a tension pneumothorax in the chest that push the trachea away towards the unaffected side. Or you might notice something called tracheal tugging, which is a synchronous pulsatile movement that occurs with systole, so with pulses when you have an aneurysm or dissection in the aortic arch. You want to palpate the neck for lymph node enlargement. Normally, lymph nodes are not palpable. If you find an enlarged node, note if it's tender, which indicates inflammation or infection, or if it's enlarged and rubbery but not tender, which is concerning for cancer. To assess the thyroid, you can either stand behind or in front of the patient. Behind typically is easier, especially for the newer nurse, and displace the trachea to the side with one hand while you're palpating the thyroid with the other hand. So here, the left hand is displacing the trachea to the right, and then the right hand is palpating the thyroid gland. Normally, you can't really feel the thyroid. If there's nodules or enlargement, you may be able to palpate the thyroid gland. Be very careful not to push on the carotids while you're assessing the thyroid, and never push on both carotids at the same time. You can palpate the carotid pulse while you're here, one side and then the other, and assess the venous pulse while the patient is lying down. This will give you an idea of right ventricular preload and the amount of backflow or back pressure that there is. So we're talking about jugular vein distension or pulsation. You want to use the bell of your stethoscope to auscultate the thyroid and the carotid arteries for bruits. And remember, a bruit is kind of a soft whoosh, whoosh, whoosh sound that you hear every time there's a pulse. And since it is a low sound, it's best heard with the bell. Respiratory sounds, so the person breathing in and out, can override auscultation of a bruit. So you want to have the patient hold their breath while you're auscultating both the carotid arteries and the thyroid. So listen to one just for a few seconds, have them breathe normally, wait, then have them hold their breath, listen again, just for a few seconds, exhale, have them breathe normally. Wait. Listen to the other side. Same thing over and over. Make sure you're pausing to allow the patient to breathe normally and to catch their breath. This is a depiction of the location of the lymph nodes. Remember that the lymph nodes are draining back into the thorax, and so everything kind of superior to the nodes is going to drain down through them. The nodes themselves give us a good idea of where the inflammation or infection may be coming from. And then some abnormal neck findings. So this gentleman here has a swollen parotid gland. This gentleman here has a goiter or an enlarged thyroid. And this young lady here has very large lymph nodes.